Thank you, and I'm Peter Adler. I'm the CEO of Molina Healthcare in Washington. Molina's the largest managed care organization with Medicaid beneficiaries. We have about 750,000 members covered in this state. Molina's also the largest health plan on the exchange, with qualified health plan under the exchange programs. So it's an honor to be here today. Our panel today is to address the challenge and the question of the health care under the Affordable Care Act over the last few years has really enabled Washington to emerge as a national poster child of success. Our uninsured rate has plummeted from over 15% to just above 5%. We have covered many people who previously had never had health insurance in this state, and we've also, from an economic perspective, seen the engine of healthcare grow substantially in terms of sustainable jobs in the healthcare industry. But that has come at a price. It has come at a significant price to taxpayers in terms of our tax dollars and the percentage of those that are paid to fund healthcare in the state. And so the question that's certainly being asked, not just in Washington, D.C., but in this state is, if we look at the last 3 years of growth and expansion in healthcare and coverage under the ACA, has it provided value to us? And two, is it sustainable in this state? And our panel today will take that question. Our two panelists sitting with me today are Pam MacEwan, the CEO of the Washington Health Benefits Exchange, and Dr. Dan Lessler, the Chief Medical Officer for the Washington Healthcare Authority that administers all of our Medicaid programs and our programs under PEB, and the expansion that has occurred over the last few years with expansion. So I'm going to make a few more opening comments, and then I'll turn to both Pam and Dr. Lessler to share their opening comments, and we'll share some questions and then open up to the room. From a managed care organization's perspective, an organization like Molina that is committed to serving low-income individuals, the ACA has been a huge success in terms of the numbers of people who now have access to care. But the question is for us in terms of sustainability, that from a policy perspective, I don't think we've gone far enough as public policy. The traditional view of Medicaid as an entitlement without an expectation of how people move off of Medicaid once they're on Medicaid, or how we actually bend the cost trends, is one that I'm actually paddling, I think, in the opposite direction of both the Democrats and the Republicans on this issue, and Molina has been, which is that actually managed care in a population-based health environment, health quality environment, is the only evidence-based approach to managing healthcare costs from a public policy perspective that actually does bend the cost curves down. And that we still have a lot of Medicaid in this state, which is not funded through managed care, but is still fee-for-service, which is really unmanaged care. And that includes oral health, and it includes long-term care services, which is a huge part of the state's Medicaid spend that is presently in unmanaged environment. And from a public policy perspective, I would argue that we would be better served by putting all Medicaid dollars in a managed environment, hold managed care organizations accountable to the taxpayer to perform, and apply evidence-based best practices to manage care to provide people with what they need, but in the right venue. That's a controversial point. That's not the position right now in many states with Medicaid. But if we're going to sustain what we've started, it's at least, I will throw that out there as an approach. With that, I want to turn to Pam MacEwan, again, who's CEO of the Health Benefits Exchange in the state. And Pam, if you could both introduce yourself and share some opening comments.
All right. Thank you, Peter. So I'm the CEO of the Health Benefit Exchange, and I have been in the healthcare space in Washington State for probably more time than I'd like to tell you about or you to know about. Anyway, I've been through many different battles with different organizations, both private and public sector. The exchange is in its 5th year of operation, and as Peter said, the Affordable Care Act is a success story in our state. The exchange was one of the first to actually be able to stand up, and in October of 2013, it was a really ridiculous timeline to build such a complicated project, and we were very fortunate that we had good people on our team and were able to get up and standing, and we spent the next couple years fixing glitches and making the system work well. So what we have now, I think, is a much more efficient system. We enroll the state's Medicaid, so I'm really partner with Dan in terms of serving Medicaid folks, and we have over 1 million Medicaid enrollees who come in through our system, and we were successfully able to automate a system that previously had not been what you would call very modern, and it's much more efficient, and we do an auto renewal process, which is far more efficient than anything the state did before in the past. We measure our success financially in terms of what do we spend per member per month, and these are really administrative costs. We're not involved in the healthcare costs. That goes to people like Peter to administer the healthcare costs. And again, we have maintained efficiency. We have really taken the legislature's challenge to reduce the number of staff that we have, the amount that we spend, and we've kept the assessment. We've avoided raising an assessment to the carriers over the past 3 years, and we've kept our staffing the same size. So that's all to the good. But it's not really where the healthcare spend is. That's not, in terms of looking at efficiency and sustainability, it's not enough that the exchange be self-sustaining. We need to look at why is it so expensive to serve the populations that we serve. We have about 200,000 of the state's 300,000 individual market members in the exchange. And that is a population that has been very, very expensive. We draw down subsidies from the federal government to pay for those kinds. So to Peter's point, those are tax dollars that are paying for those folks. And a lot of the expense of that population is something that I would say the carriers who are involved in serving them have really struggled to get their arms around. Those folks generally pay very high cost sharing. So they're paying deductibles, they're paying their premium share. The whole idea of skin in the game is, these folks really feel they have skin in the game. Unlike Medicaid, where they don't pay cost sharing, if you make over 138% of the federal poverty line, you start to assume cost sharing that goes up to quite a bit as you get to the non-subsidized range. Yet I'm not sure that makes a lot of difference in terms of how people utilize health care. There's not the transparency of pricing that is yet available to consumers. There's not an incentive or a really good way for consumers to shop for health care. And I'm not sure it's been proven that really for the big purchasing decisions, a really expensive health care, that would make a difference. I'd be interested to hear Dan and others' thoughts about this. So I think that the things that do make a difference, population-based care, managed care, working with carriers on value-based purchasing, those things are really, we don't have those tools yet in the exchange. And the past year, with the changes to the Affordable Care Act, the attacks, kind of the open hostility and partisan environment of Washington D.C. has made it harder for Washington State to focus on those things and to focus on the things that would really make a difference. But until we really get to the underlying cost trend, I don't think we can really build a sustainable system for our state. I'd like to, I think Dan goes next and see what he has to say.
Yeah, no, so I'm Dan Lessler. I'm the Chief Medical Officer at the Healthcare Authority. Just, by way of background, I'm a general internist. I was at Harborview in the University of Washington for a little over 20 years before I went to the Healthcare Authority. And I would, Pam, I would agree with actually pretty much everything you were just saying. So the Healthcare Authority, our budget is $11 billion a year. And there are people there that can tell you, as I'm sitting here, how much money is going out the door on a minute-by-minute basis, and it's sort of a staggering when you look at it. The purchase is for both the public employees of the state and their dependents, as well as Peter has mentioned, as well as for Medicaid. We purchase pretty much somewhere around a third of the healthcare for the under 65 population in the state, and that will go up because the school employees are coming in under the Healthcare Authority under a new school employees benefit board, and that's another 250,000 employees and dependents. Since I've been in this position, my point of view has been that it's extraordinarily important to provide financial access for people to care, which is what has occurred with both the Medicaid expansion and the exchanges under the Affordable Care Act. But I think quite clearly we, over the long term, unless we fundamentally change the way in which we deliver services, healthcare services, we won't be able to afford what it is we've done as a matter of policy, which I am totally supportive of. And we recognize that at the Healthcare Authority, and we certainly recognize the importance of us taking a lead in trying to drive that change, and we have been doing a lot of that, both on the Medicaid side and on the PEB side. So, really, I think fundamentally we need to move away from a fee-for-service system, which has really driven much of our problem. Though I would hasten to add that as was mentioned earlier, our problem is not just fee-for-service. Our problem is prices, because there are other, if you do international comparisons, there are other systems that are fee-for-service that don't have the same kinds of cost pressures that we face. So on the Medicaid side, there's been a lot of work with and important in terms of integrating behavioral health and physical health. So having an undermanaged care and really taking a population-based approach. This went live, and Molina, Peter's organization, and Community Health Plan are the two plans that are live with this model down in Southwest Washington, and the early returns on that, and it is still very early, but are quite encouraging in terms of the initial trends that we're beginning to see there, and that approach will extend across the state and fully encompass the state by 2020. On the PEB side, we have really been leading with innovative models of contracting, direct contracting the state with delivery systems. And so we have two accountable care programs, which really are accountable care organizations. One contract with the University of Washington Accountable Care Network, the other with the Puget Sound High Value Network, and we are about to complete our second year in that with those models of care, and again we're seeing that we're having some degree of success there in terms of really changing the model of care, away from fee-for-service, more population-based, and so forth. So, and there are other strategies such as bundled purchasing that we've gone live with, again, beginning on the PEB side, where we've seen quite a bit of quite a bit of good outcomes. And before, I'll close one observation that I'll just close with on the with respect to the bundled purchasing that we did with HIPS. And again, this is on the public employee side. When we looked at our uniform medical plan data, and we're talking about roughly 250,000 people or so, employees and dependents insured under uniform medical, and joint replacements was our largest spend, and we did close to 700 a year. And when we looked across the state at the variation in what we were paying, it was 2.5-fold. So just a huge variation in what we were paying. And the variation in readmission rates and infection rates were on the same order. So I point that out only to say that on the one hand we have challenges, but just in that one case you can see the tremendous opportunity if we can change how we purchase.
So in listening to both of your comments, it strikes me that the debate about the cost of health care and the ability of a state and our legislature to make the trade-offs with education and other discretionary line items often takes a very short-term focus. Yet the kind of things that Dr. Lessler, you were just talking about, of fundamentally changing the way healthcare is delivered, or Pam, the things when you were talking about on the exchange, that the next kind of evolution is to begin to move more managed care principles and value-based purchasing and some of the same principles into healthcare delivery on the exchange. How do we, from a public policy perspective, Pam, I'll go back to you, deal with this asynchrony that healthcare is a long-term play, whereas the funding cycle for public dollars in the legislature at best is a biennium.
Right.
But I think in recent years we've seen that it often comes down to 12-month or less chunks. How do we deal with this asynchrony of a long-term play, public policy investment, and short-term funding decisions and pressures that our legislators feel?
I think it's really a struggle. First of all, the legislators are deluged with lobbyists who are trying to protect valuable turf, i.e. income in healthcare, and there's just a myriad of interests that are pretty solid and very effective at advocating for their interests. And then the legislators are basically trying to get out of town on time and meet their budget obligations. So it's just very much pressures towards this sort of the short term, let's quick fix, get a compromise, and get done. This conference is interesting to me because I usually just go to healthcare things all the time. I get very narrow in my focus. And so listening to some of the other discussions today, when you compare healthcare outcomes in European countries, particularly West European countries, to the United States, people often blame the health system for those outcomes. But there are also social safety net programs in terms of housing, public health, nutrition, more willingness to regulate sugary drinks and what kids eat, actually regulating physical activity in school for kids, making sure kids get out and are exercising a lot, spending money on education. Those things actually have good health outcomes. So I just want to say there's a very big picture here that there are things that the health system can't fix that you can look at from more of a public health point of view. That I can tell you, this is me talking, the exchange has nothing to do with those things. But we see the train wrecks at the other end when people are in the individual market and they have really comorbidities, they're very complicated. It's kind of too late, and they're very, very expensive to care for. So there needs to be, I believe, more of a partnership between the carriers who pick up those costs and the state, and also to look at the whole continuum of care, which I think is much of the work that Dan and they're trying to do within communities. And I think this is absolutely key. One of the things Dan talked about was the idea of unwarranted variation. We have a lot in healthcare, from delivery of care to design of healthcare products, that there's variation that really doesn't provide any value to anybody, and in fact creates a lot of confusion among consumers. So one thing that the exchange would like to work on is, we know that the carriers really value how they can make their products distinctive, but they also have no idea how much they confuse consumers. We would love to see some standardization that would actually help consumers make choices among what's in front of them. And that would really require partnering with the carriers and not them seeing the exchange as the enemy, trying to, have more control over their lives or kind of work against their proprietary interests. We need to kind of get beyond that and start getting our eyes on some common goals and working towards those goals together. And that's easier said than done.
Thanks. Dan?
Well, so I guess there's I don't have an easy answer for the the time horizon of the legislature, 1 or 2 years. I would, though, point out that that same issue exists with purchasers of healthcare. So I just when again on with respect to the work that we're doing on the public employees side, and as part of what we have branded as Healthier Washington, we actually have our ACP contracts that are on the internet. You can go to Healthier Washington, you can find the contracts. The key financial aspects are obviously redacted. The reason I bring this up is we have invited any and all purchasers in the state to essentially draft off of our contract, to pick it up and run with it, and we have worked hard in various venues to try and engage the purchasing community around this kind of an approach. And let me say that these were 4-year contracts at the outset, and it is very hard to get the attention of purchasers that and employee benefit managers that looks beyond just that 12-month that 12-month time horizon. And I fear a lot of times, and this is maybe ties to your point, Pam, about managed care products and all the stuff that is out there that people are selling, that sort of promise, if you sort of purchase this system or this gadget or this app for your population, we will send, we'll save you just in 12 months and so on and so forth. So it is. It is a problem. I think the approach we're trying is just to, at every opportunity we get, to educate and try and engage both on the legislative side as well as in the business community.
Great. So we have a challenge, obviously, with the legislature on a few fronts. Financially, in the short term, of can we continue as a state to make the investments, in the short term, what are really long-term investments for return that is going to really, really financially return in the next decade? and beyond, not on our watch. So I think this is the final question for the panel, and then we'll open up to the room. It is likely, not certain, but likely at this point that funding from Washington, D.C. that helps co-fund our health care in this state and the recent expansion, both in Medicaid and on the exchange, is going to fundamentally either be slowed or reduced. I believe the question ultimately in front of our legislature and our taxpayers is going to be, do we believe in the investment, in this long-term investment in healthcare will pay off, or do we shift our tax dollars to other priorities? And so if one assumes for a moment that federal subsidy funding or co-funding is going to be slowed or reduced, last question, what advice would you give to the legislature, Pam? And same question for you, Dan.
Okay. So I think, I tend to say that to do the work I do, you have to be pathologically optimistic. So we'll start from there. And I think, and there's another expression, which is never let a good crisis go to waste. So I think that we actually are in a crisis in our state right now because of the pins that have been pulled out from under the Affordable Care Act, which has generated 34% increases in individual market premiums. So can't imagine, paying it for insurance for your own family. Some of you in this room may do that. No one can afford 34% increases on their health insurance. CHIP funding for children is hanging in the balance, and we are very, very worried about what's going to happen to Medicaid dollars, where we have such a large portion of our citizens, on Medicaid, and some of the, a lot of those, the large portion of those people are either kids or they're working, so it's not as though they're just not able, they don't make enough to purchase their own health care and their employers don't provide it. So I think that the question for the state is, I have a point, I'm going to get to my point, which is that the state really needs to pick this up. The federal government has been creating the framework. This is how the Affordable Care Act is going to work. We're giving you the money, go do it. And it's been basically just kind of following the blueprint. We need to create our own blueprint now. And we have the capability to do that. I don't think we'll be able to afford to do everything we have been doing, but this is a state that has a lot of resources. We can afford to do a lot of it. And we need to start making determinations about what's important. We need to come to the table and understand different points of view about how to administer social programs or what they should do. We all have a common interest in lowering the cost trend. And if we lower the cost trend, we can do more, and we can hang on to benefits for more people. I think we're starting that discussion now over market stability and reinsurance, because those things, again, were pulled out of the Affordable Care Act recently, and I think that creates an entree to have further discussion. That will take leadership and commitment from leadership in the legislature and from the governor. And I think that's where, and from the industry and from private groups, but that's really what needs to happen. And I think we need to get moving on it, because I don't think we have all the time in the world.
Thanks. Dan?
Yeah, so, maybe I'll just focus my comments for a second on the Medicaid piece then. I think perhaps the opportunity in that regard is trying to shape how changes to Medicaid might occur. The concern about block grants with flexibility is that if they don't take account of changing demographics, disease patterns, and disease burden and so forth, that it's just a way to sort of bluntly just cut. And on the one hand. On the other hand, I don't think there's anybody in the Medicaid space that wouldn't argue that there would be benefits from getting out from certain federal constraints in terms of how the program is administered. And so I guess my hope would be that that as a state we would actively engage that conversation and try to influence it in D.C. because I think it's likely that there will be substantial changes, but what they look like will be very important. And I think that my own sense is that there is an opportunity perhaps to find some compromise between those who want to see a very different Medicaid program and introduce flexibility, but on the other hand, those who worry that in doing that there would result draconian cuts and that there might be, even in this day and time, sort of a middle ground that could work. So, I think the other quick point I would make, just in terms of return on investment, is that, and in terms of this state, we don't have a good track record nationally with respect to mental health and behavioral health. Frankly, we rank pretty near the bottom on any metric that you would look at. And on the one hand, on the other hand, I think it's clear, as I was saying earlier, that in the short term, there probably are not just better outcomes to be had by people, which ultimately is what I think we all care deeply about, but also the opportunity to do that and actually see lower cost in a relatively short term. And I think a great example of that now is with the opioid epidemic, and the evidence that's accumulating that we're seeing just in terms of providing rapid access to treatment and so-called medication-assisted treatment is actually having in the short term quite a payoff. So I think there's opportunity there, and I think just that could be leveraged in terms of the conversations about supporting Medicaid going forward. So.
Thank you. I'm going to try to tie together both of your comments, and then we'll open up to the room. The health of the population couldn't be any more fundamental as a public good and a role for our legislature, our government, not as a dependency program, but as an investment in the future and the investment in our economy, in our population. My take from both of your comments, and I'll add my own to that, is that our legislature, we are at a crossroads, as is this country on health care. We are hurting ourselves by having one foot in and one foot out. We really can no longer afford to be halfway in on transparency, be halfway in on population health or managed care. We can't provide coverage for some of our population and not others, and then wonder why, and then pay the costs in our emergency rooms of both unmanaged chronic diseases and unmanaged infectious disease showing up at the wrong place. We can't be halfway into, Dan, your point on changing fundamentally how we pay for and purchase health care and moving ourselves completely out of the fee-for-service system. We can't stay 1 foot in and 1 foot out. And so I would argue that a summary of this is that these are public dollars. It's a public good, but with public dollars should come strings attached. The old fee-for-service model, or 1 foot in, 1 foot out, which is where really we've been in this country, is ultimately not sustainable, and we are at that inflection point. I would suggest that to our legislature, now is the time to jump in, both feet, with these programs, with value-based purchasing, with transparency, and with managed care. And with managed care do come strings. These are public dollars. And hence focus less on what is covered or who is covered, which is so much of where the public debate has centered, and instead focus wholeheartedly on how it's covered and how we take care of our populations. So not without controversy. With that, open up to the room for questions for any of us. Yeah.
Dr. Lessler, you said that everyone agrees that there should be more flexibility on the Medicaid side stuff from federal regulations. Can you get a little more specific on that? What kind of flexibility do you want to see?
So, well, I'll give you one right off the top that I struggle with right now. It has to do with pharmaceutical purchasing. So right now, under federal law, if a drug company has a drug that approved by the FDA, and if they then offer at the federal level a rebate for Medicaid, then we as a state, offering a pharmacy benefit, which incidentally is optional, but not that you'd ever get rid of that, are required to make that drug available in some way, shape, or form. We've got no discretion around how we purchase in that regard. So that's a problem. I mean, that's an example where a lack of flexibility really inhibits our ability to better manage cost and population health.
I'll add one which is maybe controversial as well, but Pam mentioned on the exchange, there's been an intentional design to have consumers have some skin in the game, some financial exposure to the costs of care, and in particular as ability to pay or income levels go up. I think within Medicaid right now, the constraint that there is no exposure whatsoever to going, not to access to care, so I'm going to be very careful about how I say this, but to seeking care in venues, in particular emergency rooms that are often way, way more expensive than where that appropriate care can be delivered, that there should be some implication in terms of exposure so that the consumer is involved and incented not to seek care, but to seek care in the appropriate setting, in the most cost-effective and clinically effective setting. I don't know, Pam, if you want to answer the question on if there were opportunity to loosen some federal restrictions, where you would go.
I think there are a lot of opportunities. I think for my world, I spend a huge amount of time on what we call CMS approvals, and actually a lot of times with Dan's staff at the Healthcare Authority. And everything is very onerous, it's not paper driven, but we're just sending documents constantly. And it uses up a lot of resources and restricts our ability to do other things. So I think there's lots of opportunity.
Great question, thanks. Others? Yeah, all the way in back.
Maybe a bit of a loaded question, so I shouldn't say who I am. Ian Goody from UW Medicine. I'm curious what your opinions are on how the Accountable Care Organization, or ACN, efforts have gone thus far. Dr. Lessler went through what those strategies are. What's been good, what's been not so good, what we need to work on?
Well, there's a lot to that. I mean, first, I think it's been good that, we've got two strong systems that have stepped up to engage a total cost of care contract, and, with with the upside, downside risk and so forth. From my perspective, I think what has gone well is actually this direct relationship between the purchaser and the delivery system. And for people who aren't as aware, we actually are holding these systems accountable to change the way in which they deliver care, and in two respects. One is that we use recommendations from what's known as the BRE Collaborative, which is a state, a gubernatorially appointed stakeholder group that actually identifies best practices, especially in areas of high utilization or practice variation, or where safety issues are salient. So they have a number of recommendations, around transitions of care, around end-of-life care, around substance use identification and management in primary care settings, and so forth. So and I think, from my standpoint, being a purchaser, being at the table with the system's clinical leadership, and actually, working to see that these changes actually happen at the same time that we actually have quality metrics that the systems are held accountable to, in terms of getting any financial gain on a year-end basis, that has worked well. I mean, I think the challenges as I see them, and there are many challenges, I think really have to do with the ability to expand, this kind of model geographically statewide. I mean, I think Peter, from his vantage point, probably sees this. I mean, it's very different trying to drive change in King County or Pierce than it is out in the Okanagan, and so these kinds of arrangements don't exist, statewide, and how how we're going to do that, I think, is remains a challenge. I think for the networks themselves, I know it's financially challenging to meet the targets, and yet overall at this point I'd say it's been going pretty well.
I don't have anything to add.
I don't either. Thanks. Any other questions? Any other answers? All right, well, we are right at time. It's 11:15. Thank you very much for joining us today. Thanks.
Thank you.